Good morning, ladies and gentlemen. The next few minutes, I'll be privileged to engage you into the health revolution that's happening in the industry through the implementation of a mass insurance program. I just want to brief the basic idea that gave life to this concept and how involvement of IT solution influenced its role. If you look at the current statistics with regard to healthcare requirement of a common man in India, as you could see here, a fair portion of them are not able to meet their expenses for specialty related healthcare services. So what do we infer from this? There is a huge rural indebtedness and escalating healthcare cost in the private hospital. Common man is not able to afford the escalating healthcare cost. At the same time, the government hospitals are not able to cope with the increasing demands of the common man. So I believe all of you will agree that there is need for a structured help for the poor. Structured help for the poor, we say that we have government hospitals and we have been talking about health for all since decades. We have been talking about health for all. But what is truly happening? The problem the common man faces are real time. And we need to make a solution. There is no more time for brainstorming. We need to make a solution for a patient who is suffering with a cardiac ailment or a malignant disease or a victim of a polytrauma who has no money to spend for his healthcare expenses, and government hospitals do not have the infrastructure to meet with the demand. So the solution has come in the form of a mobilization of public-private partnership. And this prescription has really come to tackle the healthcare challenge currently in our country. This has come in the form of a mass health insurance scheme, as the person who was introducing me was talking about. It started some 4 years before from the neighboring state of Andhra Pradesh, wherein the government thought that they should have a public-private partnership by involving private hospitals to care for these patients who need specialty related services. So the services that are not commonly available in government hospitals were enlisted, these diseases were covered, and the treatment for such diseases, the expenses for this treatment is borne by the government. So to cover the risk, the government thought that they should involve insurance. So the premium is paid to all patients, all the population by the government. So to the people it is free of cost. The government pays the premium and the public gets a benefit of free healthcare coverage. This started in Andhra Pradesh in the name of Rajiv Arogyashree Community Health Insurance Program, and now in Tamil Nadu it runs in the name of Kalaignar Kaappeetu Thittam. And we also have a program for the government employees, state government employees health insurance scheme. I just want to brief here the process workflow. A patient can reach the hospital through emergency services, 108 healthcare services, through referral from primary health centers, direct referral by the general practitioner or any secondary level hospitals, through health camps that are being mobilized and organized by the participating hospitals. So these patients, they go to the network hospital. A person from our Star Health Insurance liaise with these patients and they register this patient under the scheme. After that, the patient is seen by the concerned specialist. The necessary evaluations are being done. All records of this patient are sent online to the insurance company. The insurance company has their own set of doctors The concerned specialist doctors look into the merit of the case, and after perusal of all the documents, they approve the case. And once the approval is done, the hospital implements a surgery or a procedure, whatever is required. And after the procedure, the evidence of the procedure being done is sent again online in the form of a clinical photograph, a post-operative biopsy report, or a post-operative X-ray or echo showing evidence of surgery being done. So based on the evidence and ascertaining the outcome, the payment is made online through just a click of a button. In fact, we started this program 4 years before with 2 doctors and 4-5 executives. We used to carry fax machine, and the participating hospitals used to send their data and records by fax. And there used to be a overlapping of information, as 2-3 hospitals are trying to send at the same time. And we had a lot of environmental problems. So naturally we thought, the scheme started with a participation of 60 hospitals with a coverage of some 192 diseases. Initially we were trying to do it with some paperwork and hospital submitting the file or sending their fax and things like that. Then as it evolved into a bigger program, we thought it will be really difficult in the long run. So the success of this scheme and the model which is being taken up by other states, and it is expanding across the country, the main credit goes to the single decision of incorporating IT solution in this. Now, with the incorporation of IT solution, today, I'll just summarize and tell you, today the number of approvals we process in Tamil Nadu is around 1000, and in Andhra Pradesh it is around 1800. And the amount we disperse, it is around 3.5 to 4.5 crores per day. All these are done through a paperless transaction. So here I'll just run through the salient features of this scheme. The scheme is run by the state government, they are the regulators. Why insurance? For risk coverage. The network hospitals are the service providers, and software company, the IT solution. So universal coverage across ages. This is the first scheme for that matter to cover a patient who is newborn to a senior citizen who is 80 plus or 90 plus. Totally cashless treatment, devised packages, choice of hospitals given to the patients. So the beneficiaries, as I told you, they can reach the hospital through several services, which is all programmed and monitored through our IT system. This is one of the, on your right side, what you see is the identity card given to the public by the government in the state of Andhra Pradesh. On your left, you see the Kalaignar Cooperative Thittam card, which is a smart card. Again, it is IT enabled. The smart card contains details of the names of the family members along with their thumb impression. So this is the process workflow. As I told you, the smart card holder goes to the hospital, gets a right of free treatment, free evaluation, and the payment is made via NEFT by just through the click of a button. These are our website screenshots. These are all all the data, be it a CT film or a MRI film or an angiogram. Even angiogram procedures are sent through WebEx recording format. Laparoscopic procedures done are also sent through WebEx recording. So all these data, including the photographs and all these things, are seen, verified. The patient has gets another advantage. Here, apart from the treating consultant, there is a specialist in the insurance company who gives an indirect second opinion on this patient. Just because it is a governmental scheme, the patient cannot think that he will be taken for granted. Here actually the patient is seen by 2-3 doctors. Apart from the doctor treating him, there is a set of doctor in the insurance company and the final approving specialty consultant in the insurance team. So 2 set of doctors in the insurance team look into the data of the patients, identify the need for surgery. Once they are clarified with the indication, only then the approval is made. These are all the examples of the clinical photograph they sent before surgery and after surgery. The evidence of surgery being done. You can see the swelling that has gone in the second photograph, this operative scar, the identity of the patient is seen, and the evidence of anesthesia and the surgery being done is also ascertained. So after this 100% confirmation, we make the payments. So as I told you, indication of disease is established. An online system has largely helped us to do this, and payment is not only activity dependent, it is outcome based. How do we monitor the outcome? Again through IT solution, through a follow-up model. I'll just come to that later. This is our government health insurance program where we have done around 10 lakhs. We have done around 1 lakh plus procedures. And the disbursement is close to 300 crores. This is a Kalaignar Cooperative Thittam, where currently, we have done more than 2,25,000 procedures, and we have dispensed 600 crores. This is Aavanor, wherein, we have screened around 35 lakhs plus people. We have done surgeries on 7,20,000 people, and dispensed 2,000 plus crores. All these we are able to do it, monitor it, and successfully keep records and show to the government, to the media, or to the opposition through proper enablement of a IT solution. Apart from this, we are able to derive different data. You can see the month-wise performance, the number of patients, the amount of money dispensed, and apart from that, district-wide performance, because we wanted the benefits to reach across the state to all districts. It is not that people in this major cities, they take advantage of this program initiated by the government. This noble objective should reach across districts. Those underdeveloped districts also should utilize it. Now we have a statistics MIS data to show that which district is participating well and which is not participating. So we will focus our attention to screen more patients, to mobilize these patients, to take technology to the doorsteps of these patients who are ignorant and innocent. So this again, they are these advantages, these derivations we are able to make through the proper implementation of an IT solution. This is disease-wise. Now we know so we have record for the first time in India. We have record for what we are doing. If I say that we have done 2,25,000 procedures in Tamil Nadu, 7,20,000 procedures in Andhra Pradesh, and 1 lakh procedure in government employees, we have treated more than 1 million beneficiaries in a period of 3 years. And we have the record of all these 1 million beneficiaries. We have the details, the clinical information, the demographic profile, and the investigations, whatever taken for all these 1 million plus patients we have treated. So this is we are able to contribute to the research. See, procedure wise, so what was happening in the community, if you take a cardiology setup, most of the activities that are happening were related to bypass surgery. Although there are a lot of patients with valve disease and septal defects who are in the community, who are suffering and who are not taking enough medical treatment. And the cardiac centers, if you look into the statistics before 3 years, before the implementation of this program, maybe in Tamil Nadu, if you see before a year, if you go to any cardiothoracic department, 70% of the activity will be bypass surgery. Only 30% will be congenital heart diseases. Now, 60% is congenital heart diseases. The doctors are getting trained. The number of valve surgeries being done, the number of complex congenital heart diseases and rheumatic heart diseases being done are on the rise. Because these patients have financial assistance, they're able to come to the hospital. And the cardiothoracic surgeon who used to do only bypass surgery for the rich and affluent crowd, now he's looking into doing surgeries for the common man. And the facilities, the expertise of the surgeon in every specialty. There are a lot of newer specialties that has come up. I'll tell you, there's a microvascular surgery where they do reimplantation. A center that has been doing hardly 100 cases for a period of 5 years have done more than 250 cases in 1 year.